presentation considers the use of software in order to optimally position and place an implant for the restoration of a single tooth. In this particular case, a canine in the patient's lower left hand side. The aims of this presentation are to describe the software and its features, define the terminology used and the navigation of the software, demonstrate the application of the software to an actual case, and at the end of the presentation, hopefully you'll be able to recall the software tools that we're going to be using to position our implant, relate any anatomical features that we see three-dimensionally to the patient and planning of our implant positioning, and discuss the importance of planning to implant placement. With any procedure, obviously the positioning and pre-preparation of the implant is absolutely essential, and we'll be looking at this in greater detail as we go through the presentation. Our patient was a young, fit, healthy African gentleman, and he had quite proclined teeth and spacing in his upper and lower arches. He was quite prognathic. The lower incisors were particularly proclined, and as we look at the software and the planning and the scans, you will see how this proclination of the lower incisors affects the three-dimensional imaging, and the reading of the three-dimensional imaging. We can see that there is also spacing between the lateral incisor, the upper left lateral incisor mesially distally, and the space for the lower left canine looks a little bit large compared to the normal mesiodistal width of a canine tooth. If you look at the canine on the patient's lower right hand side, you can see that there is a small space distally to the tooth, and one has to consider whether in the final restoration we're going to close this space up, or whether in fact we intend to recreate it. And these are all conversations to be had with the patient before you start planning the case and positioning your implant, because obviously in this case we have got some latitude for adjusting the crown, but in other cases you don't, especially if it's an upper incisor, and just 1 millimeter out can have quite profound effects on the patient's aesthetics and phonetics, which are incredibly difficult to correct prosthetically because you have to work to the implant head. And that's most important to remember in these cases, that the prosthodontist is really tied to where the implant head has been positioned, and if the implant head has been positioned in the wrong location, then it can be virtually impossible to obtain a satisfactory prosthetic result. This picture again shows the spacing in the upper arch. Note the spacing to the mesial and distal of the upper right lateral incisor, and also the canine. It doesn't appear to have a space distal to it because of the way the picture is taken, and this is why it's always important to look at the occlusal view of teeth as well, because we do know there's a space distal there, although it doesn't appear on this picture. Here we can see the space more clearly, and it is quite large mesiodistally to accommodate a normal type of crown. And even the upper canine looks slightly smaller. The other thing to notice about this occlusion is that it is a class 3 occlusion, so our canine, when we eventually replace it, will be occluding partly against the lateral incisor, which is not the case in a class 1 occlusion. I'm going to now be showing you how to use software to plan the positioning of your implant with the ultimate aim of producing a guide to determine your optimal implant placement according to the plan that you're going to create using the software. So the first thing we need to do is orientate ourselves with what we're looking at. On the left hand side of your screen you're looking at the actual view, called an actual view, and if I roll my roller ball up and down, you can see I'm going through different areas of the mandible, and you can now make out the teeth. And this is the replacement of a lower left 3. So we're looking at this area here. As we go more coronally through the slices, you can see the ridge getting thinner and thinner. And this image is produced by your CBCT, and this is based on DICOM files. Now if we move to the left hand side of the screen, we have what is called an Stl file, and that is produced by a scanner, an optical scanner. And what's happened here is an impression's been taken, the laboratory has poured a model, and then following that they then scan that model to produce a 3-dimensional image of your model. The other way you can produce the model, of course, is from an intraoral scan. This is far superior in terms of capturing the gingiva, the recession, the restorations in the mouth, all the kind of things that you really can't see on a model, but which you can see from photographs and from an intraoral scanner. But of course, intraoral scanners are quite expensive at the moment and require some investment. So many of you may prefer to take an impression and send it to your laboratory to make a model and then scan it. The beauty of this is that storage is no longer an issue when it comes to study models. So we have our 2 images here, and the first thing we need to do with this image, which is our actual view, is we need to turn it into an OPG. We need to get an OPG, and the way in which we do this is we go to the panoramic button here and we click on panoramic. Now when I move the cursor back into the screen, you can see what's happening. We're getting a little cross and a circle, and I can position this on the image, and I make one click with the right button. I click again, again, and then finally click it here. And when I do a double click on the last spot, we then get our pan appearing in the lower screen. Now at the moment this doesn't show the nerve, there's some bits and pieces missing, and that's to do with where we've positioned this slice. Now we can change the positioning of the slice by clicking on any of these dots and moving them. Now when I move that out, look at the image in the lower and how it changes as a result of being that position changing. Now you can see that the nerve canal is already starting to show a little bit better because I've moved that slice. If for example I wanted to see more detail posteriorly, I can grab hold of this, click on it and just move it, and if you look at the image you can see that we're getting far more information. Now this area here, that represents the mental foramen where the ID nerve would be entering. So we could position our slice more over there, and as I do that you can see how much detail is now coming out in that region because the slice is going through there. I can again move this and improve on the image clarity, and you can imagine the nerve is running along here I can then move this area here, and again you can start to make out the lower border of the canal. What we can also do is I can scroll up and down using the twister, and I can scroll down and scroll up, and I'm moving apically now. You can see the roots, and what I'm looking for is this here, and that is obviously our mental foramen. So we really want to have that clearer, so we can move our slice a little bit, click on here, and maybe move our slicer, and you can start to see now as I move that how clear that becomes, and how we can really get an idea now of how that nerve is moving and coming down. So I'm quite happy with that. I'm not going to bother too much on this side because I don't intend to trace the nerve on that side. Now I'm now going to move to plan, because I've finished with the image, and I'm going to move to plan. And if I click on plan, immediately we see these 4 windows open up. Now at the moment in this window, what we have is we have the Stl file, that is our image of our mandible. We have our actual file, which is the actual slice through our CBCT scan. We have transverse images. This is 3 images either side of that green line. We have these images. This center image represents a slice through here, and then we have 2 other images which would be to the left, and 2 images to the right of that slice. Here on the OPG view we have the green line, and that's marking up or lining up with the green line there. So we get to see all these images from a different perspective: OPG, transverse slice, actual slice. If I position the cursor onto the OPG view and just twist the roller ball, you can see what's happening. The picture of the OPG is changing, and this is what we really want. We want to see that area there. If I position my cursor on the transverse slices and twist, I am now looking at different transverse slices through the mandible. So as I twist back here, and the green line in the bottom screen, if you look at the green line on the OPG, as I turn my roller ball, the green line is moving posteriorly, and you can see we're right in the area now of where the canine is missing. We've got a missing canine here. We can see the bone. Now as I turn in this view as well, if you'd like to look at the actual view and look at the green line again and look at the yellow line, as I turn this roller ball here, the yellow line is moving in and out, which is the one we traced earlier, and it's changing the position of the slice. So if I turn my roller ball here, the slice is outside of the mandible, it's too lingual, so we're seeing nothing. If I turn my roller ball the other way, I'm into the mandible now. I keep on turning, and this is the optimal positional, but I can carry on to turn on this view here, and now I'm coming outside of it. Or equally, I can move my cursor to the actual view, and I can roll up and down through those images and scroll up and down through those images as well. So this is giving you some idea of the navigation that we're going to be using. As you start to use the software, you'll become more adept at these, looking at these images. Now at the moment on this view here, what we have is our Stl file, and if I go to this area here and it says imported image, the Stl has been imported into the program. I'm just going to click on this little thing that looks like a loudspeaker, and if I click on that, the image has disappeared, and we don't need that for the moment. These are our segmented views, and we'll talk a little bit more about segmentation. But segmentation allows us to build up a three-dimensional image of our mandible. Now, this image isn't produced from the Stl file. This image is being generated from the CBCT data. So this is a CBCT image that we've got here. As you can see at the moment, the teeth are missing, but if I go to here, I can put the teeth back in. We have the mandible. I can switch the mandible in and out by just right clicking on it, and I can switch the teeth back in. So these are the teeth now. So this is our patient with their teeth. Now these teeth have been generated, as I say, from the CBCT file, not from the Stl file. So all this is from CBCT data. We've got the mental foramens either side for our patient. So we're all ready to go now. Now the next thing that we need to do is we need to trace out the nerve. So going to this view here, I'm just going to scroll in and out and get the best possible position here that we've got our nerve. Now, people trace nerves in different ways. I'm going to show you my way. You might develop your own way as time goes on. And the first thing to do is, obviously this is a rather small screen. We'd like to have a bigger image to work with. So if I position my cursor over this screen, click the space bar on the keypad or on your keyboard, and now we can really see that image of that canal, and we just want to draw that out. Now if I twist my ball on the mouse, I can move it in and out, but I can make that line out quite nicely. So now we have to draw in our nerve. So again, we go over to this section and you'll see an area saying nerve. Click on the nerve, and now if I move back to the image, you'll see the little cross and the dot again. And again I'm going to go dot, and then I'm going to make another click, say here, and we can start to draw in the nerve. Now at any point, if I think, oh, that's not clear, I can zoom in and out. I don't have to stay in the one image. I can click there, I can click there, there. I can zoom in and out a little bit more to there. This looks like it, and then we're coming up now towards the mental foramen. Now at this point here, I can stop. I can come out of this image by pressing the space bar again on our PC, and now if I look at the transverse slices, I can see where we are. There's the nerve. We can make it out quite nicely, and I might on this one click again, click, and then I'm just going to take the nerve outside and double click. So I've double clicked on that last spot, and if I come out of this now, we can see that we have in fact traced the nerve the whole way along that image. And we can see the nerve there coming out of our 3D image. We can see the nerve in all its glory, all the way along, all being traced through on these images. So I just see how the nerve is now travelling, how we've drawn that nerve in to its origin point there. We're coming forwards, 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 all the way through to the mental foramen. There we go. So we now have our nerve. Now obviously we need to think about planning where we're going to be positioning our canine. Now fortunately for us, we're not actually working anywhere around by the nerve. So although I've traced it in, we're not actually working there. We could go further forward of the nerve, and we could, if we wanted, we could trace the incisive branch. So what we do, got the mental nerve there coming through, and then we come forward, and then we've got this here would represent the incisive branch, maybe as we're coming round more towards our incisors and our canine and our first premolar. So we're not too bothered about that. You can see the nerve opening up here, and this would be the first. You can see actually on this particular patient it's quite interesting because the nerve is opening up slightly distally of the apex of R5, and if we look on the model here, we can see there's R5, the apex is there, and we can see the nerve just opening up in that position. And the other interesting thing we can do on this software is I can click out the bone. Now if I go to the bone, and all I do is right click on the bone, and you can see that we can now see the nerve in relation to the teeth. Now it's also possible to segment out the roots, but we haven't done that because it's not necessary in this case to do that. So this will switch back in the bone. Now when it comes to cone beams and reporting and radiography, the reports, when you get a report produced by a radiologist, they're not particularly too bothered with these 3D views. For diagnostic reasons, they always work from these 3 views, but when it comes to planning as an implant dentist, we use this view a lot more. So we'll be using this view a lot more, especially when it comes to seeing how the implant comes out. So now we've got to the point, we've traced in the anatomy, we've traced in the nerve, we now want to consider placing our implant. So again, what I do is I go back to the scouting view, always go back to the scouting view, it's the one we're most familiar with. I press the space bar, and now I'm going to scroll this backwards and forwards to get the maximum detail of the area that I'm interested in, which is this area here. Right. So I'm just going to scroll that backwards and forwards. Now we can't see this particular case. If you remember, the lower incisors are very, very proclined, so it's going to be very difficult to get one image with all the incisors on it. So even though I'm scrolling through it, I've actually scrolled through. This would be quite anterior, this would be quite labial, and I can see the incisor tips. As I scroll back lingually, I start to take a different slice. I can see the incisor tips, I can see a bit more of the roots, these are the root canals, but because these teeth are so proclined, I can't get them all on one image like I can with these ones. Yeah. So now we can see the nerve that we've traced out, we can see it coming out, the relationship of the nerve to the apex of the lower left 5, the different relationships back here, and now this is our canine, and I can turn this our first premolar, and this is the sort of place where we want to be positioning it. So I can see the root of the lateral, the lower left lateral, and this is the more of a view of our first premolar. So we need to add an implant. So now we're going to go to the implant button, and we're going to click on here, and this is going to open up our library of implants. Now in the library are quite a few different designs from different manufacturers, and these are 3-dimensional, if you like, Stl files of the implants themselves. So each implant has its own Stl file. This is all to scale. We don't really need to worry about that kind of thing. We just select the brand and the length and the dimensions of the implant we want from our library. So now we're going to be treating the 3-3 region, so we can click on the 3-3 region. We're now going to go to our implant types, and we're going to just look at what we have here, and we're using the osteotie system. So we come down and select osteotie, and there's two types of osteotie. There's a biothread design, which is a 325 diameter implant, and the 375 and the 4.5 diameter implants are called UZs, or the Uni-Easy implant, or UZ. So we click on there, and normally you can start off with, I normally start off with a 12 by 3.75. That's my standard implant dimension. You don't have to start with that, but that's a nice one to start with. You could start with the 10 if you wanted. So for now, let's say I'm going to click on the 10, and when I click on the 10, this is a three-dimensional representation of that implant, and I'm going to validate that. So I'm selecting that one. So I've selected it. Now obviously when I want it to go here, in this area here, so you can see my cursor has changed to a little implant shape, and I just click here in the area, roughly in the area, and I click, and I get this view of the implant. Now I can move this around, I can twist it left to lean it distally, and it's rotating. You can see around its apex, it's pivoting, and you can see the image has changed on the pointer to a little circle, which means I can do that. Now I can change that image to like a cross, and when I get the cross image, you can see it's got little pointers on, and that allows me to position that implant anywhere I want. Okay, I can go down there. If I do that, I'm sticking it into the nerve. I can stick it into the mouth if I want. I'm just going to position that to here. Now at the moment this is just a starting point, gives me a rough ideas of what I'm doing. Now I come out of there, and now I'm looking at this image. This is the transverse image, and we can see straight away that where it's positioned it is way too far lingual, buccally rather, labially, and I need to take the implant more this way, more towards the lingual side. So I'm moving it from the buccal more towards the lingual. So this is our 10mm long implant in this position here, and we've positioned it between the 4 and the 2, but really it'd be nice to see this now as a three-dimensional representation. So now we can go to this view, and this is where this comes in really useful, because we can look at it from the prosthetic point of view, this three-dimensional rendering. Again, we place the cursor onto the blue screen, and I can right click, and that allows me to look at the image and where that is. So although that implant is placed within bone, look where the top of the implant's going to come out. Now this would be where we're starting to build our tooth, our crown. Well, obviously we can't have a tooth this far lingually. This would be no good at all. The patient doesn't want to have the tooth under their tongue. We need to have the whole thing more buccal, but like with a lot of things, there's been some resorption. You can see how the ridge has changed here, so we need to move that more towards the buccal. So if I space my space bar again, I can come here and I can grab hold of it, and I can move it towards the buccal. So now I moved it towards the buccal to be say about there. Now this does improve matters a lot in terms of the implant head. Now remember, the implant head is very important. The positioning of the implant head don't need to worry so much about the angle of the implant. You need to worry about where the implant head is in terms of where your restoration is going to be. So if the implant head is in the wrong place, or the implant platform is in the wrong place, then you're never ever going to be able to restore it. So to demonstrate that, I can go on to transverse view. Let me pop this all the way back to here to show you now the lingual position. So now our implant head is here. The implant is within bone, but because this is all bone, remember, there's no gingiva, this is the bone. But could we restore it? No, our implant head really needs to be as buccal as we possibly can have it, but the problem you find is when we take teeth out, we lose buccal bone, and this invariably means that it's very difficult to position the implant optimally. For optimal positioning, in this case, we really need to have it somewhere like there, and from a restorative point of view, that is far more restorable. But look at where the implant is now. We're dehisced. We've actually come out of the labial bone, so that's really not going to help us very much at all. So what we have to do is look at positioning the implant head and then work around there, because it's build or design from the top and build from the base. So I'm now going to go back to here, and I'm going to slide that to where the best position I can have, which would be there. Ideally you want to have 2 millimeters of bone on the labial aspect of your implant, and this gives you a very stable implant. It also gives you a very stable soft tissue contour. You see how the trajectory of this person's mandible is. This person's got quite a prognathic mandible. And we are going to look at this again. And we'd really like to have that further out, wouldn't we, guys? We'd really like to have that a bit further out. So what we can look at, we can now look at angulation, and maybe by changing the angles of this case, we can make things a little bit more easier for ourselves from a restorative point of view. So mesiodistally it's probably about right, but buccolingually it's not too happy at all. So we can see this line down here, and if I grab hold of it, I can actually lean the implant over, or I can also lean it over from here. You can see I can turn the lean. I can, by right clicking on that, we've twisted it there, upright it, can change the shape now to that little cross, move it but distally. Look, I can pull the implant out of the bone, I can pop it back into the bone, and I'll just rotate it a little bit. Remember, when you get this circle with the little pointers on, I'm just right clicking the mouse to move it backwards and forwards, right click it, and we're beginning to see some improvement now. I might want to try and move it just a little bit this way if I can. See if I can get it a little bit more. And it's really just a matter of optimizing the positioning of that implant. So I'll come out of there. Now we can start to see how this is looking, and this is mesiodistally. I'm quite happy with that. Oh, we could change it, maybe move it a little bit that way if we wanted. Mesiodistally. Buccolingually, we got this situation. Now I've angled it, remember. So, but look at all this bone. We actually put a 10 in there. I mean, there's masses of bone, and this is a canine. So why not try and get as long an implant in as we possibly can? So it would be very nice to maybe change that to a 12 or possibly a 15. On here we have our implant sizes, and we've got a couple of options here. We can either click back into the library, and when we click back into the library I can select a 15, or to save myself time I can move my cursor up, and you can see now here it's a circle, meaning I can change and rotate the angles. Here it's a cross, meaning I can move it around a bit. But if I move over to here, it changes to an eye. And if I click on that now, if I left click on there and I just pull it down, I'm stretching it. And I'm going to stretch it, that's a 12, and I'm going to stretch it to a 15 if I can. That's now a 15. So I just moved my cursor, changed it to an eye, and then I left clicked on the mouse and held the click down so that I could stretch the implant. And if we look at the implant data box here, we can see that we're still at 3.75 but at 15 millimeters. And in the same way, if I wanted to jump a diameter, I can position my cursor over here and I could change the diameter and make the implant wider, and it's turned from yellow to this nice pink size, and we've gone to 4.5 at 15. Now I'm not going to go to 4.5, I quite like the 3.75 here, so I'm just going to drop it back to a 3.75, and now we can really start to see how this is. We've got a nice big long implant, and I'm going to actually position that implant a bit more towards the labial now, because by angling it I'm missing this buccal undercut. If I had this implant straight, I just move that to there, if I had this implant straight and like this, you can see what would happen. We would be coming out, we would be perforating labially into this undercut region, which is in the mandible here on the labial surface. If we look at that three-dimensionally, I think you'll see it better. This is exactly what has happened. Now this is a very common sort of problem. Even experienced implant people end up perforating labially or lingually, and of course if you perforate lingually in the mandible, it's disastrous and very, very dangerous thing to do. So we need to reposition that. So let's go back to our plan, and I'm going to go onto this view here, which is a transverse view, and I'm going to put it back to how it was, which was like that. But this time I'm just going to see how far I can cheat and move that forward. I've got 2 mils of bone. Look at this, 2 mils of bone. It's looking good. And let's have a look at where that is. Right, now we go with that. Now look at our 3D image. We've got a nice long implant. We've got our implant positioned with 2 millimeters of bone or thereabouts. We might be able to push that and make it just a wee bit thinner to make it more restoratively acceptable for ourselves. We've got good bone on the lingual, we're not dehissing, and if we wanted to do this as a screw retained, we're not too difficult for screw retained. Obviously we are allowed a greater leniency when it comes to angles when you're doing cement, but when you're doing screw retained, the access channel always has to come through the palatal or the cingulum, or maybe through the middle of the tooth, through the central fissure on the molars. In terms of aesthetics and accessibility, you have to be very careful when you're planning a screw retained prosthesis to make sure everything lines up and comes through in the right positioning. Cement retained restorations are far more forgiving when it comes to angles. So for example, if we wanted to do this as a cement retained, we could angle this even further forward if we wanted. Now, as I move that, look what's happening on the 3D image. Look at this 3D image here. And I'm going to just right click that. Look at that. Look, you see? And some people who have placed the implants have probably been in this position. So we're going to pop it. But I could, and I can go here and change this a little bit. I'm now working in several screens at once. And let's have a look at that. Yes. You see, now that would be perhaps more for a cement retained, but you could also possibly get away with a screw retained at that. So now I'm going to leave that for now. I'm fairly happy with that. And what we can do is I can click out the bone by going to the segmented objects, and if I just click out the bone by right clicking, I can see the relationship of the implant to the nerves and the other teeth. That's very good. I can put the bone back in by right clicking it again, and I can look at that. Maybe I'm angled just a little bit too far that way, so I'm going to correct that up. So now we've really got that nicely positioned. Now, could anybody or any implantology play with this degree of positioning? Freehand, it'd be very difficult. You've raised the flap. It'd be very difficult to position an implant this precisely. As you become more skilled, you lift the flap, you get to feel the bone, you get an understanding of the three-dimensional shape of the bone, and you can do this freehand, and many surgeons do this freehand because they can assess the bone visually. But you can imagine if you're a novice and you haven't placed many implants, then to be able to position it like this, lifting a flap, the patient's bleeding, they're jumping around, you've got this anatomy to worry about, you've got to consider your angles. Remember, if you position your handpiece just a few degrees like that or like that, you're not going to end up with the implant will not integrate, but you will have a restorative problem on your hands just by having it a few degrees out with your handpiece. Again, you could have it a few degrees out, not just in the mesiodistally, but just a matter of a few degrees out platolingually, and now the implant head has really moved towards the lingual, and it's going to cause you a restorative issue. Okay, so this is the way in which this software really helps guide you and give you predictable results. So this is the sort of situation we're probably going to go with. We could probably play with that and move it a little bit more towards the, there we are, but we want to do screw retain, so we're probably going to leave it at that, and I'm sort of happy with this. Now when you're ready, you can actually save that plan. So you can just click and you can save it as you would any other image, and then you can send that off for your template to be made. Now if we go to our toolbox here and I click onto our toolbox, there's a number of tools that we can use, measuring and angle things. One of the things that's quite useful to change is sometimes I like to change the background colour. Sometimes I like to get rid of the extender. Now the extender is just showing us the positioning of the implant head. When I take that off, you can see the extender's gone. I'll put the extender back on. So we go to extender and I left click that, and you can see by doing that I can see the positioning of where, if that was a straight abutment, I can see where it's coming out. Now just for interest, I'm going to take that implant and I'm going to move it out of the bone, and then I'm going to click onto our toolbox. I'm going to go to extender, I'm going to left click again, and look, you can see now the detail of the hex of that implant. So the Stl file is a true three-dimensional representation of the implant in the virtual world, and I can click out the bone. and I'll click out the teeth by right clicking, and if I now press on the ball on the mouse, so I'm now pressing on the ball, and if I push my mouse forwards, look what's happening. I'm zooming up on that, and then I right click, and now I think you can appreciate that you can see the internals of the implant, the hex of the implant. I can zoom up on it a little bit more, and you can see the detail of that implant. Now this is important because later on we'll be looking at ways of restoring implants three-dimensionally to make it even easier for you, but for now just remember that these drawings are not just a sketch, an artist's representation. This is a three-dimensional modeling. If you had a digital printer and fed this image to a digital printer, you could produce a replica of the implant in plastic, or if you had a printer that printed in metal, it could print it in metal, and you can scale it up and you can scale it down, and that printer would also print the internals and the hex and the post hole. So all that is there, and obviously later on when you come into place abutments, you'll need that kind of information in your planning software, or your technicians will if they're using it. You can see the nice cutting taps and the shapes of that, and this is a three-dimensional rendering. So now I'm going to put back in the bone by right clicking, and we've got the bone back in. Yeah. Now the bone, I can actually change the colour of the bone. If I want to make it a different colour, we could make the bone a nice violet colour. So we can change the colours around on all these things. We can change the colours around, but yellow seems to be quite a nice colour for the mandible. So now I'm going to position this and come back out, and we can perhaps go to this image, this transverse image here, and we can see what the implant looks like. It's within the bone. We might be able to drag it just slightly, that because we know we've got a buccal positioning problem. We could just eke it maybe a little bit further buccally. We're still in nice bone, but now it would be very nice to know what sort of quality of bone we've got here. So if you look in this area here, so go to the top left hand side of your screen, you can see here what it's saying. It's saying it's giving a D reading. If I put this to here, I've just put my cursor is in the first view there. I'm just moving it around for you, and as I do that, look at the D reading up here. There's a D reading going to appear. It's saying D5. D5 basically is fresh air, and I might position this into the tongue, and if I move my cursor now to this area and I position it here, look at what it's saying. D1, D1, D1. This is all cortical bone, it's all D1. What have we got here? D2, D2. Now look, in this area here and this area here, can you see this denser area? And I'm getting D1, and then near the top I'm getting D2 again, and then D1, D1. So this is showing us that we're going to get very good primary fixation. But we've got this dense area here, look, D1. Can you see I'm just positioning this around here, my cursor, it's showing D1. Now, when we come to actually place the implant, this is very useful information, because you know now what to expect with the bone. You're going to find it's going to be very dense to drill through at D1, so you're going to need a little bit of pressure. Then it's going to drop, and then you're going to hit this D1 bone, which means you have to put more pressure on it. So you might be wondering what's happening. I'm using my drill. Oh, it's dropped. Oh, have I perforated? Have I come out somewhere? Am I in the nerve? These are all the sorts of things that will be going through your head whilst you're doing this. But now with this, you know what to expect with the drilling. and you know, right, I'm going to feel some resistance to start with, and it's going to be quite a bit of resistance. And what I can do is, if you want to be even more mathematical, and those of you who like this kind of thing, I can click on here and I can zoom up on the image a bit. I've actually pressing on the roller ball, and I've just zoomed up that image by pressing on the roller ball and moving the mouse towards the screen. I can go to my measuring device and I can click on the measurer, and now I can position. You see that little cross? I can click on that and position that, and I've made a little dot, and then I can click on it again and I can move the next bit to here. Can you see I've measured now, and by moving the cursor, can you see it's changing to what I call a COVID virus. It's changing to the COVID virus, and I can grab hold of it and I can measure. So those of you who like measuring things, you can measure that. You can say, oh, there we go, I know that cortical plate is going to be 2 millimeters deep. So I know for the first 2 millimeters I'm going to expect some resistance, and then I'm going to get into easy stuff, and then after that it's going to get problematical. So from about here I can click again, go to my measuring stick, click here if I want, and then I go to here. I can say for the next 6 millimeters it's going to be fairly plain sailing, and then I can click on here. But I can say after that, for the next 5 to 6 millimeters, I'm going to have to work, and I'm going to have to drill up. And not only will it give you an idea of what to expect when you're drilling the bone, which is very useful when you're a novice, but also what diameter of drill to finish with. Because although you have the diameters of the drill are, if you like, matched to the diameter of the implants, which we'll look at later, there's certain situations where if the bone is very soft, sort of a D3 or a D4 type of bone, you might not go for the full sequence. So there's 3 burrs needed to take you to a 3.75 implant. You might not go to the last burr for the 3.75, but you might drop back one and use the burr that's intended for the 3.5 or the 3.25 diameter implant. So you drop back a burr size in order to just undersize the osteotomy to give you better primary fixation. Because again, what we want with our implants, you have a higher success rate if you have good primary fixation. Now remember, that's the mechanical stability that the bone gives the implant. So the more mechanical stability, the better the primary stability, the mechanical fixation of that implant, your osseointegration success rate goes up. So you don't want to go unnecessarily losing primary fixation by increasing the size of your osteotomy site when it's not needed. So again, this is very good ability for you to be able to do this and really look at things and really understand what's going on. I'm just right clicking now on the ball and I'm just changing those images down. So I don't need that. I'll just zoom that one up a bit. So now we've got everything planned. We know the precise positioning of our implant. We know the type of bone we're going to encounter, the drilling characteristics of that bone, and we also know exactly where the restorative head of our implant is going to line up at the end of the day. And when you get several dentists design things, obviously people are going to pick different implants, different lengths of implants. That's entirely up to you. I like to have 2 millimeter bone zone all the way around my implants if I can. I like to have the maximum length. I'm more interested in length than actually diameter of the implant. The diameter of the implant is probably only important in the first few millimeters. Now if we move to this view here, which is our actual view, the last thing I'm going to show you is just scanning up and down through that. So I've increased the size of the screen by again placing the space bar on there, and I'm just going to scroll by turning the roller ball. This is going apical. We're right down towards the inferior border of the mandible now. This is part of the hyoid bone for those who remember their anatomy. And then we're going to scroll up. This is the start of the genial tubercles. As we go more coronally, we scroll up. And the next thing we're going to hit, the next sort of anatomical landmark we might see, is this, which is the incisive canal, which carries the incisive nerve just as it branches off the inferior dental nerve. There's our mental foramen starting to appear, maybe. Oh, sorry, not our mental foramen's back here. There we are. That's our mental foramen. And here, this thing here, is actually our implant. And we can see the implant now in relation to that labial bone, that labial cortical bone. And we're maintaining a reasonable distance as we're going more and more coronal. There we are. So we can get to see, there's the bone on the lingual, there's the bone on the labial. Again, very little bone. The other thing I'm looking at also is the space from between these teeth. Now, if you look here, we go to the crown here. This is the crown around these teeth. Here you can see this, and there's bone here. This is the canine on the other side. Now, to me, this space is quite large for a canine. A canine would be about 8 to 9 millimeters mesiodistal width. So we can look at that as well, and we can go to our measuring stick. And from the root, I'm going to make a click on the root, double click that there, and I can click to there, and I can measure that distance between the click, and I'm just going to move that to there. Right, and we can see that that's 9.6 millimeters, which is quite wide for a canine. So we'll look at that in a bit more detail on the clinical pictures and on the final restoration. We positioned our implant between the roots. There might be situations whereby you might want to position the implant a little bit closer to the 3, because if you want to make the crown of the 3 more in keeping with the crown, you're going to have spacing. And you have to decide, do I want spacing mesially and distally? Do I want to try and close up the spacing, or do I want to position the implant a little bit more mesially and have a little bit of space towards the distal? What is sometimes referred to as the anthropoid space, which is a space distal to your canines. So you could go for an anthropoid space, a little bit distal there, but you might decide I want to go in the middle and try and close that gap up. The one big advantage, of course, is if you position that more mesially, and I'm just going to take it more mesially, as you move mesially or distally, the head of the implant, and this is just moving the head, it's not changing any angles, as we move that mesially and distally, we're actually moving into denser bone, because you see, or sorry, more volume of bone, because you can see the bone, the ridge bone, is always widest where it leaves the teeth either side, because the roots are maintaining the bone there and maintaining the bone. Once you lose the tooth, of course, the ridge drops in, and this is why you end up positioning the implant too far lingually, because from a restorative point of view, the crowns need to be out here in the labial. So our root is really too far. If we think of the implant as being a root, our root is too lingual, isn't it? So we would ideally like to have our implant head around about here to really get a crown that fits in line with the labial surfaces of the other crowns. But we can't get that because of this lack of this bone. Another way around this, of course, is to graft, is to put a big bone graft, but you'd have to put a block graft in here, which would mean the patient might have to give up a piece of his chin, which some patients in certain circumstances are happy to do. But remember, when you start doing that, there's donor site morbidity, a second operation or procedure to harvest the bone, place the bone, wait for the graft to take. The graft may not take, you may get an infection. There's all sorts of complications with grafting. It's not as predictable as you might think. Here we can see there's a good width of bone here, so you could, by positioning that implant either there or there, make things a bit better for yourself because you have more bone, especially here. So sometimes you might choose to go just a little bit further back, especially if the restoration will allow you to do that. So we'll leave that there, then we're going to scan up, and the other thing I'm looking as I'm scanning up and down, I'm just rolling up and down up through the actual slices. As I'm scanning, I'm looking at the relationship of the circumference of the implant to the roots, because I don't want at any stage for the implant to end up being too close to the root. You need to maintain at least a 1.5 millimeter space between your implant and your tooth all the way along. So again, if you're working in a very confined space, okay, we've got nearly 10 millimeters of space here, which is huge for a canine. But suppose we'd lost space, which is more often the case. If we'd lost space and we had like 5 millimeters of space, obviously positioning that implant has to be optimal, because half a millimeter one way or the other mesiodistally might end up sticking it into the root of the teeth either side, or the periodontal membrane space, which again could be detrimental to the whole process. So using this view is very useful to just look at the bone all the way around it. Look at this bone zone, this biological width of bone. We need 2 millimeters, 1.5 minimum. From our root we need at least about another 2 millimeters, another 2 millimeters. What they say normally is you can probably go to 1.5 on the buccal, then 4 for diameter of your implant, and then the remainder 2 millimeters or so would be on the lingual. Okay, so that's 1.5, that would give you 4, which would be 5.5, which gives you about another 1.5, because we're working in 7 millimeter units. Remember, 7 millimeters, very important. That is an implant unit, and we'll be discussing that more as we go along. That's 7 millimeters, because it helps you to plan. Right, okay, so we're moving up and down. We are happy. Okay, so we'll come out of that. Now, you save the image, and then the next thing you will do is you will send that image to your laboratory or to your template maker, and they will go on and make your guide. And this will be based on this planning that you've done. And that guide is a precise, custom-made measuring device for your patient. And that's why the guides are not cheap to have made. They're printed, they're very accurate precision instruments. They're not made from a bag of cold cure on top of your model, but they're made, and the rings and everything are precisely made to guide the drills along this trajectory, so that we have no doubt about where we're going. So now all that remains to do is for you to send this information to the printers or to your laboratory and start making your template.